Hello, my name is Brian Jonas. I'm at the University of California Davis Comprehensive Cancer Center. This will be a presentation on the prognostic factors in AML. AML is associated with poor outcomes related to treatment resistance and relapse. The 5-year overall survival for all adults is 24%. AML prognosis is influenced by many features, which include patient-related factors, AML-related factors, and post-treatment-related factors. Patient-related factors primarily relate to ability of patients to tolerate therapy and the risk of treatment-related mortality. Patient-related factors include age, performance status, comorbidities, and treatment location. For example, using the California Cancer Registry, we showed that treatment at an NCI-designated cancer center was associated with a 50% reduction in early mortality. AML-related factors, on the other hand, primarily relate to the chemosensitivity or chemoresistance of the disease and its propensity to relapse. And these factors include cytogenetics, molecular genetics, history of prior exposure to cytotoxic agents or radiotherapy, history of prior or antecedent myelodysplastic syndrome or myeloproliferative neoplasm, and white count at presentation. Several genetic risk stratification classification systems have been created. For example, on this slide, we see the 2007 ELN genetic risk stratification. And these systems use both cytogenetics as well as molecular genetic lesions to characterize AML into various categories, such as favorable, intermediate, and adverse risk, as you can see here. These risk categories can be used to predict disease-free survival and overall survival for patients when considering their prognosis. And this information can be used by clinicians to help guide post-remission care for patients. Post-treatment-related factors primarily relate to treatment resistance and propensity to relapse and are becoming more and more important in the management of AML. These include achievement of complete remission and minimal or measurable residual disease. In the case of achievement of remission, this has long been known to be prognostic. For example, lack of response to 2 inductions is called primary refractory AML, which is associated with dismal outcomes. And recently, additional subcategories of remission have been established, but it's been found that responses less than full complete remission can be associated with poorer outcomes compared to CR, but of course, better outcomes compared to no response whatsoever. Regarding MRD testing, this is also a relatively new field in AML, and there's still a lot to be learned before it becomes routinely used in practice. But MRD is measured in AML either using flow cytometry-based methods or molecular methods. What we do know is that MRD is highly prognostic for long-term survival as well as for success post-transplant. Further evidence of the increasing importance of MRD in AML is shown in the most recent ELN 2017 guidelines, where MRD negative complete remission is now included as a separate response criterion. Furthermore, it is becoming apparent that there is potential role for combining both flow and molecular MRD data to have a combined prognostic impact in determining outcomes for patients with AML. So shown here on this slide is data from recent European data showing that there's a potential combination effect of both flow and molecular MRD in this patient population. For example, the risk of relapse is significantly higher in patients with MRD positive, both by NGS, which is next-generation sequencing, and multi-parameter flow cytometry. Several prognostic models have been developed to aid clinicians in guiding treatment decisions for AML, and they include genetic risk stratification systems, such as was shown earlier in this talk. Some other examples include AML score, Prognostic Index for Cytogenetically Normal AML score, the AML Multistage prediction model, and the European Prognostic Index for relapsed AML. Many of these models attempt to integrate some of the prognostic factors mentioned previously, including patient-related factors, AML-related factors, and post-treatment-related factors, to help guide decisions, including choice of induction therapy or treatment post-remission. On this slide is an example from the AML score, And this model can be used for helping consider whether induction chemotherapy or high-intensity chemotherapy is a reasonable option for older patients. And it uses various variables that are both patient-related and AML-related to give estimates of complete remission and early death with induction. On this slide, I show the PINA score, which helps give information about predicted overall survival and relapse-free survival for patients in remission with cytogenetically normal AML. This uses features including both patient-related and AML-related features. A newer model called the AML Multistage prediction model attempts to integrate not only patient-related and AML-related factors, but also complexities between interaction of different mutations that affect prognosis. This model potentially has a more of a precision approach for AML care, again through this integration of the various mutations that a patient may have, and to help determine or help recommend post-remission treatments, for example, whether the patient would benefit from a allogeneic transplant or not. This slide shows the European Prognostic Index for AML and first relapse. And of course, relapse is a major issue in AML, with more than 50% of patients relapsing. And this model takes various features, both patient-related, disease-related, and treatment-related, to help determine prognosis for those in first relapse. To conclude, AML is associated with poor outcomes, and AML prognosis is influenced by patient-related factors, AML-related factors, and post-treatment-related factors. Accurate prognostication is imperative to help guide optimal treatment recommendations. Thank you for listening to this talk. Hopefully with this talk, you've been able to learn more about the way that we determine prognosis in AML.